Antinuclear antibodies, ANA, are typically positive in systemic lupus erythematosus, SLE, but there is a small subset of patients who have ANA negative SLE. The possible causes or explanations for ANA negative SLE include 1. Technical factors. Different laboratories use various methods to detect ANA, and some methods may be less sensitive, leading to false negative results. For instance, ELISA tests might miss some cases that are positive by indirect immunofluorescence. 2. Low ANA titers. Some patients may have ANA at low titers that are below the threshold for positivity in certain assays. 3. Antibody variants. Patients may have autoantibodies against nuclear antigens that are not detected by standard ANA assays. For example, antibodies to SSA-Rho can be present in ANA negative SLE. This is especially seen in subsets of patients, such as those with subacute cutaneous lupus erythematosus, SCLE, or neonatal lupus. 4. Antigen accessibility. In some cases, the antigen targeted by ANA might not be readily available or exposed in the laboratory conditions used for testing, leading to a negative result despite the presence of autoimmune activity. 5. Seronegative variants. There might be true seronegative variants of SLE where the disease manifests without the typical ANA positivity. These cases can be diagnosed based on clinical features and the presence of other specific autoantibodies or criteria for SLE. In ANA negative SLE, the diagnosis often relies heavily on clinical judgment and other laboratory findings, such as anti-dsDNA antibodies, anti-Smith antibodies, or other clinical criteria consistent with lupus. The zone phenomenon, or prozone phenomenon, is a laboratory artifact that can cause false negative results in serological tests, including ANA testing, particularly when the antibody titer is high. In this phenomenon, an excess of antibodies, e.g., ANA, interferes with the formation of visible antigen antibody complexes, leading to a false negative or weakly positive test result. Here's how this happens. Mechanism of the zone phenomenon. Excess antibodies. In normal antigen antibody reactions, when the concentrations of both are balanced, visible complexes form and can be detected by the assay. However, when there is an excess of antibodies, as may occur with very high ANA titers, these antibodies can saturate the available antigens. This saturation prevents proper lattice formation, cross-linking between antigens and antibodies, which is necessary to produce a visible reaction in many immunoassays. False negative results. As a result, the test fails to detect the presence of antibodies, leading to a false negative or falsely low ANA titer. This situation can occur in indirect immunofluorescence assays, ELISA, or other antibody detection methods if the test is not properly adjusted for high concentrations of antibodies. How the zone phenomenon affects ANA testing. Dilution resolves the issue. To address the zone phenomenon, labs may perform serial dilutions of the serum. Dilution reduces the concentration of antibodies, which can then allow proper antigen-antibody complex formation, leading to accurate detection of the ANA. In patients with very high ANA titers, proper dilution is crucial to avoid false negative results. Relevance in clinical practice. While the zone phenomenon is relatively rare, it is an important consideration when interpreting serological tests, particularly in cases where there is strong clinical suspicion of SLE or another autoimmune disease, but the ANA test is negative or weakly positive. In such scenarios, retesting with serial dilutions or using alternative testing methods may be necessary to obtain accurate results. In summary, the zone phenomenon may cause false negative ANA results in patients with very high antibody concentrations by interfering with antigen-antibody complex formation. Proper dilution of the sample is often required to detect the antibodies accurately. The starting dilution of serum in the assessment of antinuclear antibodies, ANA, by indirect immunofluorescence, 2F, is typically Quine 40 or 180. 140 dilution. This is often used as a lower threshold to ensure that low titer ANA can still be detected. Some laboratories may consider ANA positive at this dilution. 180 dilution. Many laboratories use this as the standard starting dilution to reduce the chances of detecting non-specific low-level ANA, which may occur in healthy individuals or in conditions other than systemic lupus erythematosus, SLE. Further dilutions, such as 1 to 160, 1 320, etc., are performed if the initial test is positive to determine the titer of the ANA, which can provide additional clinical information regarding the potential severity or activity of the autoimmune disease. The most important anti-nuclear antibodies, ANAs, in clinical practice are those that are associated with specific autoimmune diseases, particularly systemic lupus erythematosus, SLE, and related conditions. Here are the most clinically significant ANAs. 1. Anti-dsDNA, anti-double-stranded DNA. Significance: highly specific for SLE, especially in cases of lupus nephritis. Clinical use: often correlates with disease activity, particularly in renal involvement. 2. Anti-Smith, anti-SEM. Significance: highly specific for SLE, though less sensitive, found in a smaller percentage of patients. Clinical use: diagnostic marker, but does not correlate with disease activity. 3. Anti-SSA-RO and anti-SSB-LA. Significance: found in SLE, Sjogren's syndrome, and subacute cutaneous lupus erythematosus, SCLE. Associated with neonatal lupus and congenital heart block in babies born to mothers with these antibodies. Clinical use: important for diagnosis and managing pregnancy risks in patients with lupus or Sjogren's syndrome. 4. Anti-RNP, anti-ribonucleoprotein. Significance: associated with mixed connective tissue disease, MCTD, and also seen in SLE and other connective tissue diseases. Clinical use: helps in differentiating MCTD from other autoimmune diseases. 5. Antihistone. Significance: primarily associated with drug-induced lupus. Also seen in idiopathic SLE, but less specific. Clinical use: important for diagnosing drug-induced lupus, especially in patients taking medications known to cause this condition. 6. Anticentromere. Significance: associated with limited systemic sclerosis, CREST syndrome. Clinical use: important in the diagnosis and prognosis of systemic sclerosis, especially the limited form. 7. Anti-SCL70, anti-topoisomerase 1. Significance: strongly associated with diffuse systemic sclerosis, scleroderma. Clinical use: helps in diagnosing and predicting the severity of scleroderma. 8. Anti-Jo1. Significance: associated with polymyositis and dermatomyositis, particularly in cases with interstitial lung disease. Clinical use: important for diagnosing inflammatory myopathies and assessing lung involvement. 9. Anti-PM-SCL. Significance: associated with polymyositis scleroderma overlap syndrome. Clinical use: useful in diagnosing overlap syndromes involving scleroderma and myositis. 10. Anti-nucleosome. Significance: another marker for SLE, especially associated with lupus nephritis. Clinical use: can be used to monitor disease activity, particularly in renal involvement. These ANAs are central to the diagnosis and management of various autoimmune diseases, particularly connective tissue diseases. Testing for these antibodies is an essential part of the workup in patients suspected of having autoimmune disorders. Anti-nuclear antibodies encompass a wide range of autoantibodies that target various nuclear and cytoplasmic components. Here is a list of the known ANAs categorized based on the antigens they target. Part 1. DNA-related ANAs. Anti-dsDNA, double-stranded DNA, anti-sesstranded DNA, antihistone, anti-nucleosome, chromatin, histone DNA complex. 2. Ribonucleoprotein complexes. Anti-Smith, anti-SM, anti-U1RNP, ribonucleoprotein, anti-SSA-RO, anti-SSB-LA, anti-RNA polymerase 1, 2, and 3, anti-PM-SCL, anti-RNA helicase A, anti-fibrillary U3RNP. 3. Scleroderma-related ANAs. Anti-centromere, anti-SCL70, topoisomerase 1, anti-RNA polymerase 3, anti-fibrillary, anti-TEC2. 4. Myositis-related ANAs. Anti-Jo1, histidyl-tRNA synthetase, anti-SRP, signal recognition particle, anti-PL7, threonyl-tRNA synthetase, anti-PL12, alanine-tRNA synthetase, anti-OJ, isoleucyl-tRNA synthetase, anti-EJ, glycyl-tRNA synthetase, anti-KS, asparaginal-tRNA synthetase. Ashra 5. Lupus-related ANAs. Anti-ribosomal P protein, anti-PCNA, proliferating cell nuclear antigen, anti-MPO, myeloperoxidase, anti-C1 antiphospholipid antibodies, e.g. lupus anticoagulant, anti-cardiolipin, anti-beta-2 glycoprotein 1. 6. Other connective tissue disease-related ANAs. Anti-MPO myeloperoxidase associated with vasculitis, e.g. microscopic polyangiitis. Anti-PR3 proteinase 3 associated with granulomatosis with polyangiitis, Wegener's granulomatosis. Anti-CPB, centromere protein B, associated with limited systemic sclerosis, CREST syndrome. 7. Miscellaneous ANAs. Anti-SB100 associated with primary biliary cholangitis, PBC. Anti-GP2110 also associated with primary biliary cholangitis. Anti-HU, paraneoplastic syndrome. Anti-YO, paraneoplastic cerebellar degeneration. Anti-RE, paraneoplastic opsoclonus myoclonus syndrome. 8. Cytoplasmic ANAs, anti-mitochondrial antibodies, AMA, associated with primary biliary cholangitis. Anti-SRP, signal recognition particle, anti-smooth muscle antibodies, anti-actin, anti-liver kidney microsomal antibodies, LKM1, anti-Golgi complex antibodies. 9. Nuclear pore complex antibodies, anti-GP2 antibody against nuclear pore complex proteins. 10. Histone modifications, anti-acetylated histone, anti-methylated histone, anti-phosphorylated histone. This list encompasses many of the known ANAs that are relevant in various autoimmune and connective tissue diseases. The presence of these antibodies, often in specific patterns, helps clinicians diagnose, monitor, and manage autoimmune conditions.